Today we are discussing about a case which is recently had a judgment, and it's very interesting one. I'll just go through the case in brief, probably like 10 or 12 slides. I'll just give the glimpse what exactly had happened, what was the opposing party and complaints, what a series of event and when what time went on. Then we'll move to the discussion part. So we have a complaint who is a husband and a wife. Wife is deceased and referred to as a patient in this following cases. OP, that is opposing party 1, is the hospital. OP2, that's opposing party 2, is the senior gynecologist of the hospital, that is OP1. Opposing party 3, that is OP3, is the anesthesiologist of the hospital. So on 16th 4, that is 16th April 2010 at 6:30 a.m., the complaint 1, that is a husband and his wife and their family members came to the hospital. And at around 8 a.m., the anesthesiologist met that is OP3, met the complaint, that's husband and wife, and discussed about the general anesthesia or epidural, which was supposedly given for a LSCS, cesarean section. So the wife is a young female who was about to deliver. It's first baby. It has about to be delivered. Next, the gynecologist, that is OP3, stated that as advised by the gynecologist, the anesthesiologist stated that as advised by the gynecologist, that is opposing party 2, he will give a general anesthesia to the patient. So the complaint 1, that is patient party, again spoke to opposing party 2, that is the gynecologist, about the general anesthesia, who assured him that there would be no complications. So the gynecologist herein assured the family members, the husband, that there wouldn't be any complications for giving a general anesthesia. Next, she did not even advise for any pre-anesthetics checkup, is what the complaint said. I mean, she, in the sense, gynecologist did not advise for any pre-anesthetics. On 16th of April 2010 at 9:15 a.m., the patient was taken to operation theatre. At the same time, even the gynecologist entered the OT. So at around 10:15, the complaint 1, that is the husband and the family members, suddenly noticed a flurry of activities, and all the senior doctors and the staff from the hospital, including the CMO of the hospital, rushed inside the OT. There was something happening inside the OT, which the complaint, that is the husband and the family members, were not at all aware. So now at around 10:40, the gynecologist informed the complaint 1, that is husband and the family member, that his friend and his friends, that the patient was given a general anesthesia, and 1 in a million patients may react violently to the drug. The gynecologist also informed that due to severe anaphylactic reaction from sodium thiopental, an anesthetic drug, which we all know, the condition of the patient became very critical, and the doctors were trying to revive her and shifted her to the ICU. The complaint 1, that is the family members and friends, repeatedly inquired the gynecologist as well as the anesthesiologist about the condition of his wife. In fact, the gynecologist also mentioned that there was a very slim chance of survival. In her words, as she said, she is as good as gone. So the gynecologist has totally made that she is not going to be revived or cannot be survived, in her words. So the OPs, that is 2 and 3, anesthesiologist as well as the gynecologist, had shown little concerns and anxiety while monitoring the patient. So there was no apprehension that the patient could be survived and we need to do something. It was further alleged that the gynecologist was trying to selectively isolate herself from this situation, as she told the complaint that, "Look, I haven't even touched your wife." These were the exact words which the complaint or the husband or the family members have quoted. That has been told by the gynecologist. So At 11 a.m. on the same day, that is 16th April 2010, at 11 a.m., patient was taken to the ICU. At around 11:50 a.m., patient and her unborn child were declared dead. Thereafter, the doctor and the hospital authorities insisted the complainant one to take away the dead body of his wife at the earliest. It was further alleged that the gynecologist did not even assess the condition of the baby and failed to save the baby even with the help of surgery. The complainants alleged strongly that his wife had died in OT itself. However, to cover up their negligence, the doctor tried to show it as shifted to ICU. Therefore, the actual reading of the monitor were not available on the record. This was the thought of the complaint one, that is husband, family members, or the husband's friend. Now the ICU. Okay. Now the ICU monitor showed 0 reading, which itself confirms that the patient and unborn child were already expired in the OT table at 11:30 a.m. The gynecologist made a casual attempt to note a fetal heart sounds on a dead body, and even a USG was actually done at 12:05 to 12:08 p.m., which was noon, which was 15 minutes after the death. Hence, the complaint, that is the family members, registered a FIR at a police station stating an unnatural death on 16th of April at around 4:30 p.m. So 4:30 p.m. is the time of registration of the FIR, but the time of death declared is much earlier. The copies of medical papers were seized by the police from the hospital and were handed over to the complainant one on 23rd of April. The cause of the death mentioned in the intimation letter was cardiorespiratory arrest, which was secondary to acute anaphylactic reactions. On 17th, the very next day, the postmortem was performed and the copy of preliminary reports were handed over to the complainant on 26th April 2010. And the preliminary report of the postmortem recorded following findings, which includes fracture of left sacroiliac joint with plenty of clots in the muscle in front of the joint. Second point is peritoneal cavity contained 1,500 grams of clot and 200 ml of blood in the fluids form. Next, mesentery, transverse, and left mesocolon were confused. So these were the preliminary findings of the postmortem. The viscera and the blood were further sent to the forensic science lab for the chemical analysis to find the anesthetic drugs and sedatives, etc., any other medicines. And the organs were sent for the histopathological examination as well. The histopathological examination report received on 13th of May showed mesenteric mesocolon hemorrhage and severe congestion. The forensic science lab, Professor Forensic Science Lab report received on 27th of May revealed that anesthetic drug thiopental was not present in a detectable limit. So the thiopental medicine were not present in a detectable limit. In the final postmortem report, the cause of death was given as shock and hemorrhage as a result of injury to pelvis sustained. Upon the receipt of the preliminary postmortem report noticing the injury, a further FIR was lodged on 4th of May 2010 and a case of medical negligence. Here, the complaint further alleged that the hospital case sheet were fabricated with a numerous overwriting and insertion. Thus, an inconsistency this inconsistency raised more suspicion on opposing parties, that is the gynecologist, the anesthesiologist, as well as the hospital. The BP was not recordable as early as 10:10 a.m. itself, and many places the time of death was changed from 10:50 to 11:50 a.m. So in July, the police arrested OP2 and OP3, the gynecologist as well as the anesthesiologist, and 4 other medical staff, and they were released on bail. On 7th 8 2010, the complaint filed a complaint against complaint in KMC, Karnataka Medical Council, against OPs under professional misconduct and malpractice under the regulation. Again, the consumer complaint before his commission was alleged medical negligence and prayed for a compensation. So these were the actual events which were happened during those times. These were the actual ask of the family members. So one could see, based on the post-mortem report, there's a huge something fishy is what happening looking at the case scenario. So in this kind of situation where something happened inside the OT and which has not catered to the attenders or the family members, so it becomes little tricky situation. And how one, either the gynecologist or the anesthetist, should handle in such scenario. First thing is, what I would notice is, hiding something from the family members or attenders is not something good or something right to be done, but the event has happened. So how do we proceed after such things? If any uneventful or something which has happened, should we go and openly say, and what would be the attenders' reaction, how we should approach such scenarios? Sir, I would want to start with you, Mani sir. Could you please take this question?
See, this is absolutely a nightmarish situation. And once in a while, I've also found myself in this situation. And because something totally unexpected, untoward may happen in the OT. An adverse reaction, anaphylactic reaction, an idiosyncratic reaction, suddenly producing cardiac arrest. Now, I assume that all the OP2 and 3 and 4, they had honest intentions and they are people of honor. Okay, firstly, I start with that assumption. If you had an adverse reaction, right, and culminating in the death of the patient, the last thing one should do is to sound, defensive. Which is what the gynecologist perhaps did. She was very quick to try and protect herself, saying that I hadn't even touched the patient. That very often surgeons do that, but that's very counterproductive because it gives the impression that you're insensitive. So that won't do. The best approach is to call them and tell them quite frankly what exactly happened, right? And then take it on the chin, whatever reaction happens. You do that with the security and others. I think I did write a story, exactly how the conversation flows and how to settle the emotions, right? It needs a bit of bravery. In all conversations of breaking bad news, it needs bravery. It needs honesty. It needs empathy, right? And nobody can teach that. You have to practice it. That's it. Now, the things not to do is to not tell the whole truth. Number 2, fudge papers. Number 3, try to be defensive. Now, all of these are counterproductive. If you manage a conversation well, it may not even reach the courts, okay? And see, what I think, all this post-mortem reports is very surprising and bizarre to my mind. This can't happen unless the patient fell from the OT table. It could have happened that, that is a total disaster. Okay, you have nowhere to hide. But, at least if you confess to that happening, it won't be regarded as a crime, but as an accident. They are two different things. So to my mind, the I think it could be different. Reality could be different, but I think the basic principles of breaking bad news were not followed, and you know, the basic rule of not hiding facts, you know, that has been flouted, is what I think.
Yes, thank you, sir. Thanks a lot. Dr. Manik, any thoughts on this?
No, I mean, absolutely. I agree with all what Dr. Mani has said. Those principles need to be there all the time. They have been broken, unfortunately, in this case, when you read the document for the whole document. And there is no way anaphylaxis. I just want to go to a bit few details of the case. Like, you know, when a case like this with anaphylaxis secondary to thiopentone, you're putting it forward as a differential. It would be lovely to have rashes visible on the body in support of your diagnosis. However, I mean, we all know that anaphylaxis may present without the typical rash, or the rash may go away, or the rash may be slight. But the question which undoubtedly remains is that, you know, because the OPs put up very strong defenses in their, in the whole document, saying that thiopentone goes away, giving the physiology of thiopentone, so it is undetectable. Anaphylaxis may not be always be accompanied by a rash. There was no fall because this, and from the orthopedician getting evidence, so they were very technical. Like, if you read the document, they have the lawyers and the medical staff have put in quite a bit of effort to defend themselves in the right spirit. They've got an orthopedician saying that such kind of fracture happens from high velocity accidents. From a 3 feet height, it is unusual. Saying that they have also described that this blood could have come from a path which goes from, and this is typical, a very specific of anatomy, saying that the blood trickled down from the heart to the kidney around there in the pelvis as a result of CPR. Are they saying that? But in any case, the final question which remained in the document, if you read that, was, if this was anaphylaxis, how did you have 1.5 liters of clot inside? Those two just don't get along. The two diagnoses cannot be, like, they don't go along with each other. Like, you cannot say sometimes two diagnoses can coexist, but anaphylaxis with 1.5 liters of blood inside with clot, what's this happening? So irrespective of so you have to agree that there was a fall there. The second thing is, I must say that in terms of fudging the documents, the data from the monitors inside the OT, which was reviewed by an IT company from Hyderabad, was it was clear that the data had been taken out, meaning it had been completely removed. There was no data. That means the blood pressure, the vitals, where did they all go? Why was all that data taken off? If you are taking that data off, that obviously you are guilty, right? Why? So I think these issues concern me. Complete lack of transparency, taking off information very visible in the case, and physiologically your diagnosis is not compatible with the postmortem. So unfortunately, a very badly dealt case by the whole hospital. A very unfortunate case that sense did not prevail in amongst in any of these senior specialists. I mean, I'm speaking harshly, but these are senior specialists, and somebody should have said that you cannot be making up a case. You cannot be making up a case. And if you look at the final, in the end, who's paying the money? Who's found guilty? The hospital and the anesthetist, because the obstetrician, the court held that he didn't, she didn't touch the patient, and the person who said this was anaphylaxis, whose responsibility it is, the anesthetist, and who fudged the all document, like in the hospital system has allowed it to happen, right? So I'm sorry, but I don't have any soft words for this case. We are absolutely guilty here, 100%. There is no defense for us in such a case. You have done wrong here. How can you take away the information? This is absolutely wrong. I mean, I can't be soft about it. I'm sorry, on screen, I'm saying such harsh words. And I've always supported people that we are honorable people, and I expect people to be honorable. But where is the honor here? There is no honor here. Honor is gone in the dustbin. You've put it in the bin when you made that wrong diagnosis. Empathy has gone in the bin. You've told the husband of a young lady that she has died, and all the obstetrician is concerned about is, this angers me. This is a young patient. First of all, it's an unfortunate. Instead of being empathetic, the obstetrician is only concerned that I have not touched the patient. Why? Can you not have some common sense here? So I feel they're absolutely, I think they should have asked for more money from the hospital and the doctor. I have no sympathy or empathy left.
Yeah. Thanks, Monica. Next question, I just want to ask Ujjwala, then I'll come back to you, sir, Dr. Arun. In a perspective of a law, in the code, if we consider it could be a fall from a table, because it looks like a fall from a table. Now, who will stand guilty? Is it the gynecologist? Is it the anesthesiologist responsible to make sure, or is it the hospital or the ward staff people? So, what is the scenario in? How does the court takes it?
So, I mean, actually, the court is only going to take. So, there's an allegation and then there's the defense, right? So, essentially, what has happened in this particular case is that the patient is obviously alleged, based on the postmortem report, that there was a fall and there was not enough care was taken, and the hospital has been negligent and the doctors have been negligent. And I think, of course, there were many opposing parties, not many doctors, including the pediatrician, etc. But the defense was actually completely different, right? They denied a fall. So actually, there was no admission at any point in this particular case of a fall. So I don't think at any point the court had to decide on who was guilty for the fall. So if you understand how, the court works, is that basically they're judging whether this, you're guilty of negligence or not. They're not actually deciding who is responsible for the fall. And in many ways, I would believe that if the defense was actually that the fall happened and it was, a genuine, and in spite of all care taken, we took X, Y, Z steps, and what a reasonable person or reasonable doctors would have done in that situation, we did all of that, and in spite of that, the patient fell. Maybe the court would have actually looked at it much in more consideration or more considerately, rather than looking at it as an act of guilt or as a criminal act, or in this case, right, or a negligent act. So, but that was never the sequence of events that happened, and the sequence of events was completely, denial of. In fact, they actually at many points in time, like Dr. Monica said, they challenged the postmortem report. They tried even to get medical experts to opine that, like, for example, a SI joint fracture cannot happen from 3 feet, and, so on and so forth. They even tried, I think, to make it like she had a congenital defect of the spine, and, try to connect it to that. And, it actually went in a very different direction. Probably at some point, even the people in the case they couldn't walk back because they'd gone so deep into denial that they couldn't. So I don't think at any point the court, to answer your question, had to decide whose fault it was. But I think if that question arose, it would largely be on the hospital, because the hospital's responsibility is to provide the infrastructure for the operation to happen, and I think it wouldn't fall on a particular individual; it would fall on the hospital as a whole. Is my understanding.
Okay, thanks, Monica. So, Doctor, just one question with respect to this case. So, in this scenario, the main approach to a patient or the family members should be fair, and she should have come out openly, is what the idea of handling the situation, and they would have probably told that no, these things happened, but unfortunately these events sustained. So when something of such happens, like let's say the gynecologist comes and openly says that such things have happened, so there might be difficulty in the accepting from the family members. It's not as Manisha was mentioning, like breaking something bad which has gone wrong. So how do we handle such scenarios? Because it was a acute incident. It's not like a everyday ICU patient who comes in, we tell like this is so bad, next day I mean the condition deteriorates day by day or every hour or afternoon. So such scenario, how should this be handled in the acute phase, like not expected, something bad really happened? So how do one proceed to handle such, how should they express, or how should they tell, let's say the gynecologist tell the attenders?
So thank you, Dr. Rajesh. I think the biggest, the nightmarish thing which happened in this case was things were going too fast. Probably everything happened in about next 30 to 40 minutes. And probably the direction that the entire medical team took was completely different. They went into a complete defense kind of a situation, and they did not team up. Probably we can even see there was a break in between even the anesthesiologist and the gynecologist. So they were going into two different directions, and probably at that point in time they felt that the anaphylaxis theory would probably be the safest theory, because one would not be able to prove it or disprove it. What went against them was the postmortem findings. So two things practically went against them. The first thing was the postmortem finding, and second thing was the fabrication of the record, which was picked up by the court. So I think when and if we come across this situation, we've had these situations in our ICU, a tracheostomy gone wrong, a tracheostomy done and a patient develops a surgical emphysema and hemodynamic instability. I think what needs to be done is we need to take time together for about 5 minutes, decide first thing should be to resuscitate the patient. In the meantime, a senior person in the team, the first person has to be the person who's the primary physician of the patient, because the patient's trust would be into that person. So this person goes out, tells the family about the facts. Do not make assumptions or deductions at this stage. So the question would be, why did that happen? A simple answer would be, at this point in time, we are resuscitating the patient, and we would give you the information as and when the information comes. I think that is the first point. You need to have repeat updates, regular updates, involve your medical administration, involve the patient's nurse or a nurse who's present in the OT, go together. You should all look like a single team, talk to the family and talk facts. Honest disclosure, I think, would have been difficult at that point in time, but I think the end result which happened would have been different had the disclosure been honest.
Thank you, Dr. I have one more question, then it's open for the audience. So in such scenario, something bad happens. So is there any system or any organization which helps the doctor to handle such cases, like from the law side and from the doctor side? Dr. Mani, Ujjwala, Monica, Dr. Arun, yeah, just want to know, like, are we safe? Let's say something happened.
Help you seek afterwards, Rajesh, help you seek afterwards.
Yes,
First of all, common sense. You don't need help to use your common sense. Be honest, tell the truth. Don't fudge facts, because facts will come out. No matter what you do, the more you try to cover up, more they will tend to come out, and more damning they will be. Because obstruction of justice, as Ujjwala will tell you, is a crime in itself. Right? So if it is very evident something has happened, borne out by facts, and you have covered it up, now there is another criminal proceeding that can take place. So I think, firstly, don't look for any help, artificial help. Firstly, you do the rules have to be followed. Okay, tell the facts, and don't try to justify at the outside. As Arun said, you first just relate the facts with as much composure as possible. Okay, that is very important, and as much empathy that you can garner. And number two, At all times, be close to the truth. See, although it's the toughest thing to do, and many times you have to counsel yourself before you go and talk, okay? And that is worth doing, okay? Mindfulness, focus on what you want to say and telling yourself the first principles of not hiding anything. You can use different words, you can use it, more sensitively, but you have to tell the facts. And then record as such. Record the facts as such. Do not erase any record. In this instance, erasing digital records is a crime in itself. So you don't create another criminal scene for yourself, right? So you don't do these, and then you can find ample help. See, there are people specializing in criminal jurisprudence and in medical negligence cases. So that comes afterwards. You don't have to be legally very well educated, to be honest. You've got to be ethically grounded. You've got to be sharp in communication skills and in humanistic understanding of the situation. Situational awareness is very important. Now, as a critical care specialist, situational awareness is very, very important skill, right? Otherwise, your reflexes are not appropriate. So these can't be taught by anywhere, or you can't get support for this. Now, as Monica said, this is indefensible. Now, what are you going to do with this sort of thing? In the last case, I would have stoutly defended the medical side. But in this one, it is totally indefensible because somebody is lying. How can you protect that? How can you cover it up? And the lying is, prima facie, right? It is can't be subjected to any interpretation.
Yes, sir. My question, I would slightly tweak it. Let's say everything went in a right, he come out very fair, open. The doctors told so we are actually sorry, but the attender still in a denial phase, went to court, filed a FIR. At that scenario, then is there any?
Rajesh, everybody has a right to seek court redressal. Everybody,
True,
anybody,
True,
whether you were in the right or not. We should be prepared for litigation. Only thing is how well you can defend it. Okay. From the medical side, these are the principles I've told you. You need a good drafting of response, then you can go to a good lawyer. Or you can develop a sort of legal cell within your own hospital, which gets better and better at it, drafting these replies. But you must not leave it to the legal firm. I have understood that no matter how good you are medical legally, the doctor's inputs are extremely important. You should be drafting your own replies, point-wise. Draft your own replies. They can be then the legalese can be added. Okay, legal jargon, legal orientation can be added, but you can't escape and run. You got to take responsibility. Whatever happened has to be related, and every complaint has to have a rebuttal, point-wise. You can't just be wishy-washy about any of them. Each one has to be rebutted properly, logically, and it may be supported by references. Okay, if you say that this happened due to pentothal, attach references of how many cases have been reported. So even if it is one and it is rare, well, it can happen, no? Okay. What is rare can happen in a particular instance. So that is a support. So you have to do all that homework.
Good.
So, Dr. Rajesh, can I say something?
Yes, sir, please.
Sir, Dr. Mani sir, the interesting part about this case was that the medical defense which was prepared was good enough. The expert opinion had been taken from another anesthesiologist. They had taken an opinion from an orthopedician. They had in fact taken an opinion from multiple other people. So in fact, there was no challenge with the medical defense. But again, the case actually went against them because everybody, if you read this case, then what you understand is there was something fishy. In fact, any medical person would be able to pick up that this does not seem like a thiopenton anaphylaxis. There is something which has been hidden. So I think this is what even the judiciary interpreted. And so I think how they started off, probably they couldn't turn back from it, and that is something which went against them. There were certain good things. They informed the police by themselves. They did not withhold the medical records. The medical records had been handed over. They did not resist post-mortem examinations. So there were certain things which were done by the book, but I think the first lie which they took up went against them in the end.
See, Ujjwala will bear me out. I'd like to ask her, see, the medical opinion is taken by the judges, but it's not incumbent upon them to follow that, in total. It has to match with the rest of the information. All right, you have to fall from a height of 10 feet. That can't happen in the OT. However, there is a pelvic fracture. It doesn't happen like that. And it didn't pre-exist. There is no evidence that pelvic fracture pre-existed. And see, fall from any height can produce serious damage in a pregnant lady. And it can tear the placenta or whatever, mesentery, and you can produce a huge amount of clot in the abdomen. This is common sense. You see, it doesn't need terrific medical expertise to put two and two together. So things must add up. You can't just put together a medical opinion and favorable opinion and expect that, somehow things will fall in place. It's not like that. It has to make sense.
So, sir, what's interesting for me is I understand that doctors at that point in time probably panicked. And, this is a result of what happened there. So their immediate response was that. What I would actually be most interested, maybe to know is, in due course of time, and we know that this took 10 long years, more than 10 long years to come. What happens when at some point, a doctor or any party for that matter says, you know what, I want to actually change my statement. I want to say that this is actually what happened. Now, this is a very complicated situation to be in because you have so many other people who are actually part of that. They're not part of this. In this case, I think 3 to 4 cases were going on simultaneously. They probably the effort, time, money, energy, loss of reputation that all the doctors have suffered and the hospital was probably much more than, probably what they were scared of initially. The fear of that was what probably drove them to do this, not any, particular bad intention. But then the outcome was probably way worse than what, they could have anticipated. So, a real question, and I see this because when I have, like a doctor coming and asking me some advice, they always don't want to say whatever the group is saying is what their defense. And if you look at the fact that they found the anesthetist and the hospital guilty, I feel like it's a very important lesson that sometimes, all doctors need not follow the group. I think it's very important to realize that as far as the law is concerned, you are a separate opposing party and you are entitled to come up with your own defense. I think oftentimes doctors choose to go with the same lawyer that the hospital may go with, or this, kind of group together and do it and say, I'll just show up if I need to. But I don't think that's okay. It's more so when you know that there has been a deliberate change of facts. For example, I think what Dr. Monica spoke about, which is that the OT monitor, the ultrasound device, as well as I think the fetal monitor, they've deleted the records on it. And actually these devices were seized almost a year later, if I'm not wrong, but many, many months later. And yet it's so easy to recover these records because we may delete something on even what we think we delete on our phones, but there's always a record of the fact that that record was deleted. It's so easy for these things to be traced and tracked. And that's what happened as well in this case. So, I think they have recovered the OT records where probably the patient was, not even alive by the time they shifted this patient. So these are very easy facts to uncover. And I think to roll back, sometimes we may do panic and do these things. And I think that sometimes it's natural to do so. And it's very difficult in that moment to defy the group, right? You cannot stand up and say, no, I don't agree with it. But I think at some point in your legal defense, to stand out and say, this is the stance I'm taking is also critical, because yes, you may lose some friends, but I think you also may end up, doing the right thing by yourself and by the patient.
But see, if the responses are different, let's say you hire two different lawyers for the same case, and your responses are different and not in sync with the sequence of events, then wouldn't that mean that you would actually lose the case at an earlier level as compared to at a later level?
Possibly, yes. But I think you may also, I think the standards for finding a doctor guilty are very, very high. So unless you did something deliberately to which resulted in the death of the patient, you're not going to be found guilty of death or negligence or criminal or whatever grievous injury in this case. So I would say that you have to remember that each party has to watch out for itself, right? In this case, the gynecologist saying, I did not touch the patient, right? That's kind of, what happened. But that's very important, because I think you will end up with a guilty, I would say, guilty verdict eventually anyway. And which is what happened even in this case. So I agree, it may harm your case in the short run as a team, but sometimes, I mean, I especially mean when there are very glaring deficiencies, I think you should not feel the pressure to side with whoever is insisting on continuing the false theory. I think the law will look upon it much more kindly on that party. See, I think a doctor admitting that, let's say, there was a mistake will not be held as, I would say, the judge will not be as harsh as if, because I think doctors have been, not been penalized for many things, which when they've admitted for, that this is a mistake that happened. So the law does not hold doctors to such a high standard. And I think that's important. I think the fear of that is what drives people to do these things. And I think it's important to know that you need not be scared. The law does not expect that the doctor has done something extraordinary. For example, in this case itself, one more thing that the complainant alleged, that they could have done a post-mortem cesarean section and saved the life of the baby. They even got expert witnesses who opined that you could, ideally in such situations, you have to, within 15 minutes, you have to do a post-mortem cesarean section. But I don't think the judge gave any credence to that expert opinion. Because it is not so common for a doctor in that situation to think, we're trying to revive the patient, that I'm going to do a post-mortem C-section. It is not, it's not what an ordinary person would have done. So hence they did not hold that, the doctor to that standard.
No, Ujwala, that is quite a standard consideration in the medical field. You have to try and save the child. So it won't be unusual. I think I was also wondering why there was no attempt to save the child, because, that is also because there are two lives. And
so in fact,
one life could have been saved out of the two.
So in fact, when we teach the adult cardiac life support algorithms for the pregnant patient, the algorithm is very clear. You've started resuscitation of the mother. Within next 5 minutes, if you think that the mother cannot be resuscitated, immediately perform a cesarean section and take out the baby. Save one life.
Absolutely.
That's a
standard protocol.
That's a standard protocol. So in fact,
that's right.
So whether you are in a mental state to think of it or not is not the issue. This is a well-discussed situation in medicine.
But my point is that the judge did not hold that standard, since it is not as common practice. That it's not easy. So what I'm trying to tell you is, while yes, actually doctors may be more critical and saying, no, it should have been done, the judge did not actually address it and saying it's fine. It's fine because it can happen. So what I'm trying to tell you is the standard is not so high. The expectation of what a doctor would have done in that situation is not of the highest standard. It's of what an ordinary doctor would do in that situation.
True.
Yeah, that is the Bolam rule.
Yes.
That protects us many times, even from very substandard treatment.
True.
Yeah. So we have a question from Dr. Sanat. He wanted to know the gynecologist has requested for general anesthesia, but it's the anesthesiologist job and to identify what needs to be given, either a spinal, epidural, or general anesthesia. So you wanted you all to have a slight comment or slight discussion on that. How would the gynecologist ask for something like this? Because it's a whole and sole anesthesiologist responsibility and decision.
Monica is there. Monica will take this question.
I think the choice of anesthetic for a particular patient is decided by a few factors, isn't it? One is the medical decision, which is decided by the anesthetist. That means based on patient's age, comorbidities, is there a particular risk versus benefit ratio? In benefit of regional, in certain cases there might be. And if the risk benefit ratio is equivocal, both are equally good, then is there an emergent indication in terms of delivery of baby, like fetal distress? And is that going to be faster by GA because of 1, 2, 3 reasons? Spine is abnormal, patient is not cooperative, XYZ reasons, then it is justified. Or is the patient determining? The patient refuses either GA or regional. So there can be few reasons for the choice of anesthetic, therefore can be based on patient's comorbidities and the advice given by the anesthetist. So that's the decision. The patient accepts also that, okay, I'm happy to undergo a regional anesthetic. Or it might be a indication as discussed with the obstetrician that it is fetal distress, right? So we got to choose the fastest approach to save the baby. So when in this case, the gynecologist said, I want GA because of maybe the spinal problem the patient has, she's made a call on that. And if as an anesthetist you disagree, then you disagree. If you think regional is better, you should make that call, isn't it? Because that's your specialty. And you got to then convince the obstetrician that I'm going to give regional. I think regional is possible. It is fast. There is no fetal indication for GA. And I think regional is equally good and the patient is going to cooperate. So final responsibility of the anesthetic, of course, lies with the anesthetist. And therefore, another party cannot be making a judgment unless there is a reason for it, like a fetal reason in this case. That's the call of the gynecologist, the obstetrician gynecologist. Is the baby safe? Can the baby wait for GA or regional, or does the baby need to come out fast? So I think in this case, that was not the case, isn't it? There was no fetal distress issue here.
Yeah, thanks, Monica. Thanks. Yeah, Arun, sir,
I just want to comment on this case. Now, this case is about a fall leading to the death of a patient, and falls are common in hospitals all over the world. In the best hospitals, falls are happening with the best infrastructure, problem-oriented approach, AI, whatever. Everybody's using technology. So the question here is not whether falls are fully preventable or not. Like, what are you going to do with that fall when a patient has like bleeds in the brain? We have bleeds in the brains happening to patients, elderly patients. They can bleed anytime. So are we going to hide that information and land up in a worse soup like this one? Or are we just going to be transparent? And then the question will be, how did the hospital handle the complication of the fall? Was the neurosurgeon consulted? Or in this case, it's a more maturer system. I would have said would have handled with transparency, and the court might have still had a complaint, but the issue would have been of clinical care delivered. Was the general surgeon called immediately? Was the obstetrician ready to open up the abdomen since there was hemoperitoneum? Was hemoperitoneum suspected? So these are the clinical questions we would be asking in a mature system where information is not hidden. Here, information is being hidden. So once, as Dr. Mani said, and as Arun is saying, and as Ujjwala is saying, once you start hiding evidence, you are a criminal already. Irrespective of whether you're a doctor or a nurse, why are you hiding it? Why are you fudging it? So, as I said, these falls will happen in all hospitals. We have to be prepared for it. of how the hospital management and the system, everybody is going to handle it. I think there is definitely no question about it that this will not happen again. This will happen again and again. Thank you.
Yeah, thanks, Monica. So, are there any questions from the audience? We're almost about time to finish. Anybody has any questions?
So many times, of course, complaints are exaggerated. And that the only way to rebut that is to actually show the data on pre-anesthetic check. PAC is a must in every hospital, I presume. Yeah. It's mandated.
Yeah, the very fact that the complainant was mentioning that the anesthesiologist spoke to them before surgery about the anesthesia, that itself looks like there was some pre-anesthetic checkup which has happened. Probably the family members didn't know what exactly the pre-anesthetic checkup was and all sort of things. Second thing, what I would see in this case was a gynecologist performed a fetal FHS, so probably she might thought of saving the baby. Just a thought on the case, what has been reported.
So the indication for cesarean is also not clear.
Yes, sir.
So many of the medical data are missing, of course, because the context was different. How such a situation develops and how to handle it. That's the context. And the legal implications, of course.
I don't think there are any questions from the audience, so shall end this session for today. Thank you, Dr. Mani sir, Dr. Arun sir. Thank you, Monica. Thanks.
Thank you all for listening in.